Okay, so today we will be continuing our combined stations approach. In the previous session, we discussed about abdominal examination and testicular examination. Today we will be discussing about ear examination and antenatal examination. So ear examination is one of the most important one. It's fine. Okay, so ear examination is one of the most important one because it is one of the it is only scenario which comes with a child, and all the other scenarios comes with adult patients. So we will be seeing that how to approach such kind of stations in which there is a child, and how to show the examiner that we are safe and a kind doctor. There are three stations. In first one is the acute otitis media, and there are two earwax stations. One is the follow-up, one is the first presentation. And then there are two antenatal examinations, breech presentation and cephalic examination. Okay, so again, important points are the same. Like the previous session, we discussed from the GMC website that whenever you are going to examine, you just explain first what you are going to do, and then take consent, and then perform examination. And during examination, warn the patient whenever you are going to touch, and at the end, say thank you. These three or 4 points, whenever you are going to examine, you need to do all these 3 to 4 points. Rest of the part, like the history taking part, is the same like the previous scenarios. Like Dr. Hamid has told you about everything about the history taking part. So rest of the scenario will be same, but the examining part will be slightly different, and we will be discussing that how to approach in ear examination and in antenatal examination. Same, you will be having a good 90 seconds outside the room, and you will be reading your task. Now you will get an idea that you have to perform something. It would be written in the task that perform relevant examination. So you have to perform that relevant examination, enter into the room, have a smile on the face, be confident, greet with the patient, start taking history. Usually, these rooms are slightly bigger than the casual rooms, like normal ones, because they have mannequin on one side, either on the right side, on the left side. So you will get an idea outside the room in the scenario, and second, when you will enter the room, you will get an idea that it's the combined station. I have to perform the specific and relevant examination. Then again start your history taking, and when you go to the examination part, explain that now I'm going to examine either I'm going to examine your ear, or I'm going to examine your tummy for antenatal examination. And if the patient come like if there is a child, like 10 months old child, then you have to explain the procedure to the mother and take consent from the mother. And then again, focused examination. If you have to examine just ear, just go and examine ear. There is no need to perform Rini or Weber's test, and there is no need to mention those tests when you are going to perform only ear examination. And then at the end, say thank you. And before performing examination, like if you are inserting otoscope into the ear, warn the patient, and then explain findings in a way that the patient can understand, or the mother can understand that what's wrong with her baby. And at the end, give the probable diagnosis that I am suspecting that this is this condition, so we're going to manage accordingly. Then management and referral and safety netting and warning signs. So this is the general approach. We follow this approach in all in all the scenarios of abdominal examination, either it's ear examination, testicular, or antenatal examination. So let's discuss ear examination. Yes, yes, you have to take history a little bit. Uh, it's these scenarios are same like history taking scenarios, but you have to perform examination in just 1 minute or 1.5 minutes. I will show you the videos. In the videos, you will see that those the candidates, the the students who have made those videos, they perform similar examinations in 2 to 3 minutes, but you have to cut those examinations and keep relevant yourself to the examination. We will be discussing it, that how you have to perform these examinations in 1 minute. History is important. Otherwise, look, there's a concept behind this. In these stations, you are going to make a probable diagnosis, and to make a diagnosis, you need examination. Either examination would be in the form of in the written form on the paper, or you have to perform that examination. If it's not on the paper, then obviously you have to go there and perform physically, confirm your diagnosis. Or if let's say the patient comes with a child. Okay, child comes 10 months old. He's 10 months old and he's having ear problem. Now you have taken a good history. Now you need to confirm it. Without examination, you cannot confirm either it's acute otitis media or acute superiority external otitis media or acute superiority otitis media, whatever. Other like it's meningitis, so it's simple fever. So to confirm it, you need to examine. So that, you have to show this to the examiner that I'm going to examine it. So if they give you the findings, then it's fine. If they don't give you the findings, then you have to examine. So this is a simple concept that either you need to confirm your diagnosis. To confirm diagnosis, you have to examine. So it's important. The history taking part is important, and examination part is important. Both parts are important to do this do these scenarios. Okay. Approach is same. It's just a simple. First, we will be discussing about the approach, and then we will be discussing scenarios one by one. You introduce yourself that I am one of the doctors. I am Dr. Junaid. I am one of the junior doctors here. I need to examine your child's ear. So it involves inserting an instrument called otoscope in the ear. It should not be painful. I will remain as gentle as possible. Just give some just the baby is 10 months old. The mother is worried. So just give some relaxing lines that it shouldn't be painful. We're just going to insert it, see that what's going on. So these are the reassuring lines. And then take consent. Should I proceed? Can I continue? Can I examine your child's ear? And then if there is an adult, like if you are going to examine for earwax, then ask for is there any pain? It is possible that if the adult comes and he is having difficulty in hearing, it is possible that infection is going on. There is a possibility that there is an inflammation behind the ear. So before performing any examination, ask if there is any pain, then just one line to get an idea. Okay, then the inspection part. Inspection, you have to inspect three things: pinna, mastoid, and preauricular region. Inspection usually takes only 5 to 10 seconds, not more than that. In real life settings, just examine your own ear or your brothers or your friends or whatever whose ear. You will see that just it would take not more than 3 to 5 seconds, and it should not take. Obviously, you're going to perform examination, so you cannot spend 1 minute on inspection. You should not just verbalizing those steps like I am examining pinna, I am examining mastoid, I am examining preauricular region. No, don't do this. Just now you're performing. You are not teaching. You're performing. Just examine like in 3 to 5 seconds. And then palpation. Whenever you're going to palpate, if you're going to touch tragus or the preauricular region, you're going to touch the patient. One, okay, John, I am going to touch your ear. If you feel any pain, just let me know. One, and ask for pain. That's how you're going to ask about tenderness. If you don't ask for the pain, then how would you know that there is a tenderness? So before touching patient, warn the patient and ask if there is any pain, just let me know. Then palpate is the lymph nodes. Usually they are mannequins, so they are no lymph nodes, so there is no need to do this. Just palpate it. The patient will continue. या परेशानी रात की है, लोगों की समझ में बात आ रही नहीं. Okay. And then otoscopy. This step is important. Okay, whenever I have seen the candidates who perform otoscopy first time, even they are unable to hold otoscope in their hands. So there is a proper way to hold otoscope. If you are going to examine right ear, remember you should use your right hand. Right ear, right hand, left ear, left hand. And hold the otoscope like a pencil, like in this picture. In this picture, you can see that he is holding the otoscope like a pencil, and from the other hand, he is holding the ear. So you have to follow these steps. I have written these steps here. So ensure that first check the light, if light is working or not. Then throw some light on the ear to check for any discharge, any redness or any swelling, and then pull the pin upwards and backwards. From your other hand, if you are examining right hand, from the left hand, you can pull the pin upwards and backwards, and then position the otoscope. Now, if you are going to examine the right ear, right hand, and when you are going to insert it, just warn the patient. I am going to insert the otoscope in your ear. If you feel any pain, just let me know. It is possible that there is this tenderness, there is a swelling inside the ear. So when you insert the ear, the patient might feel pain. So he would warn you, he would tell you that there is a pain. You can change your diagnosis on that point. And whenever you're going to advance, warn the patient and be gentle. Just involve the patient, just like the original settings. Involve. All right. So these are the speculum. The speculum you have to attach it on the otoscope. This is the speculum. And at the end, thank the patient and discard the speculum. There are three sizes. Usually, in the real exam, there would be two speculum there, and they would in the acute otitis media with the child, there would be two otoscopes. One is a smaller otoscope, one is the larger, bigger in size, and there would be two speculum. I have just put there a picture there so you can differentiate what speculum is used for adults and what speculum is used for infants and children. So you need to be careful at that point. Always pick, when you are going to examine the child, always pick the smaller otoscope and smaller speculum. This is smaller one and smaller otoscope. So these two things are important. There will be two otoscopes and two speculum, remember. And one more thing, the mannequin would be of adult size. So don't confuse yourself at that point. So it's the simple approach that how you are going to examine ear. Inspection, palpation, and then otoscope. There is no need for palpate lymph nodes. There is no need for Rene or mentioning of Rene or Weber test at this point. You need to just examine inspection, palpation, and then otoscopy. These three steps, and you can do these three steps in 1 minute, under 1 minute, easily. You can practice. I will be showing you the video. You can practice with a pen or any other instrument. Like it should not take more than 1 minute. Okay, so this is the simple approach for ear examination. Let's see our first scenario. When we will discussing the scenario, it would be easier for us to understand how we are going to complete this station in 8 minutes. It's acute otitis media in a child. This scenario is pretty much important because most of the candidates fail this scenario, and there's a simple reason behind it. Even I, in my original exam, I told you in the previous session as well, I failed only this scenario, and the reason behind, I was not acting as a safe doctor. And I will be telling you that what things makes you a safe doctor. I showed you GMC guidelines as well. Today I will also show at the end what the GMC guidelines say, how whenever you're going to examine, how you show yourself that you are a safe doctor. How? First, explain what you're going to do. Second, take consent. Third, warn the patient. Fourth, thank the patient. So you need to repeat these steps. And if there is need for chaperone, then or for chaperone, but in ear examination, there is a mother. There is no need for chaperone. Mother is always there with the child, so there is no need for any kind of chaperone. So let's see. Okay, So who you are a Vatu, 10-month old child has been brought with a fever, not feeling well. Talk to the mother, take history and manage and address her concerns. Okay, now you're standing outside the room. This would be your scenario. You enter into the room. You will see a chart, news chart, in front of will be placing on the table, and these observations will be written in the beginning before asking these observations will be there on the table before you ask for any observations. Okay, you enter into the room, you greet well, you smile, and you can pick those observations. You can see that, okay, I can see that your child is having fever because temperature is 39, and there's a little bit, the child is 10th month old, so heart rate is 146. It's slightly above the normal. It's not that much high. Okay, so when you are going to enter, you enter into the room. You start after greeting. You ask about the child. So how can I help you, or what brought you here? I can see that your child, or whatever the name of the child is having high temperature. So if you are starting like this, if I can see that there's a high temperature, then start taking history from the fever. Like when did you notice, and for how long? Like those questions, the history taking questions that you ask normally. And have you noticed any other things like neck stiffness? Rule out all other things. So I have seen, I after the feedback that I got from the candidates, some candidates even missed the diagnosis. Even they could not diagnose acute otitis media. The reason was that the mother, continuously will telling you that, doctor, my child is not feeling well. He is not feeling well. He is not eating. He is not feeling well. Whatever, mother would not say this that the child is pulling her ears, yeah, or his ears. You need to ask this. When there is a fever, you need to rule out few things. In differential diagnosis, if there is 10-month-old child, there could be problem with the tummy. You can ask about the diarrhea, constipation. There could be problem with there could be meningitis. About You can ask about neck stiffness, and it is possible that there is respiratory tract infection going on. You can ask about flu or cough. If the mother is saying that no, nothing, doctor, I have noticed nothing, then you can ask. You should ask. Have you noticed that your child is pulling her ear? So that is where you would know that the problem is in the ear. If you do not ask this, the mother would not tell you that she or he is pulling her ear. Usually, the child is female, so mother would say that she is not pulling her. Would not say that she's pulling her ear. You have to ask this specifically. But before that, you need to rule out all other differential diagnoses, including respiratory tract infections, abdominal infection, meningitis, which is common, pneumonia. It comes in respiratory tract infections. So these 3 to 4 infections are common among children. So you need to first rule out, then you can ask, have you noticed that, okay, Jessica, have you noticed that your child is pulling her ears? At that point, mother would say that, yes, doctor, yes, I have. So when did you notice? Yes, since yesterday. Okay. So have you noticed now? Now the things are getting clear in your mind that the problem is in the ear. And there is a fever, there's a problem in the ear. Now go for the history. Have you noticed any discharge? Have you noticed any redness outside the ear? Have you noticed any? Did she suffer from trauma? Ask about 3 to 4 things about ear to rule out any ear pathologies. Okay, so when you will ask about the discharge, have you noticed any discharge? The mother would say that, doctor, I do not know. Yesterday, she was with my sister, and my sister told me that there was a greenish discharge. So you would say that, being a doctor, you would say that. Are you sure that that discharge from mouth, or was it from ear? She would say that, doctor, I'm not sure. My sister was telling me that it was on the pillow. So there is a confusion. There is a confusion that there was a greenish discharge, but no one is sure that either it was from the ear or it was from the mouth. Usually, there is no pathology in which there is a greenish discharge from the ear. It is possible that it came from the mouth. So yes, surely UTI is one of the common condition in the children. So you can ask that. You can ask UTI questions like this. Have you noticed your child cries whenever she pees? Or you can ask the question like this to rule out UTI as well. That's great. Okay, so one thing, child is pulling her ear. Second thing, there's a discharge. Discharge is a confusing thing. Don't confuse yourself. Go on. Okay. So there is no much history about discharge because the mother's sister noticed it, and it was yesterday on the pill. There's you will be asking any other question. She will be saying, "I don't know, doctor. My sister noticed that." Okay. Now you have ruled out disease. You have asked a few questions. Now those questions about the child development. Usually ask about the development, about the pregnancy, about the immunization status, and those four to five questions. You are taking now. You are taking history, and you have now the things are getting clear that there's a problem in the ear, and there was a discharge, but not sure from the ear or from the mouth, and there's a fever as well. So fever plus ear pulling is common among children. It's and when you will ask about the history for how many days, it's 2 days. So here it's making sense that it's acute. If it's more than 4 or 6 days, then you can think about chronic states. But it's for 2 days, so things are getting clear that it could be something acute. So fever and pulling her ears and 2 days history. Acute otitis media, the things are getting clearer. Okay, after asking about the child's developmental milestones, and immunization status, birth history, you move toward the examination. Remember, observation has already been done. There will be a news chart on the table, and you have seen that there's a temperature. Okay, Jessica, whatever the mother's name, I can see that a child is having fever. The observation has already been taken, but to confirm my diagnosis, I need to examine a child's ear. So it involves an instrument called otoscope. So I would be inserting that otoscope in your child's ear. It should not be painful. Can I proceed? That's how you have explained that what you are going to do, and you have taken consent as well. Now you have taken consent. She would say, "Okay, doctor, yes." You will stand up from your chair. There would be a mannequin, the similar mannequin like this. This hand. Okay. Let me see if. Okay, I will show you the mannequin as well. Okay, just. Just similar to this one. So there will be a mannequin like this one. But remember, you're going to examine child. You're not going to examine adult. The mannequin would be adult. You go there. On the right side or left side, there would be two otoscopes. One would be of the bigger size, one would be of smaller size, and two speculum. Now, stand there, just think that this is child 10 months old. Pick the smaller one, and pick the speculum which has like a narrow opening, because you are going to examine child. This thing is for the examiner, that I understand that she is 10 months old child. As for that, I need to select this narrow speculum and smaller otoscope. Now, again, you have taken the consent. Observation 3 minutes, 3 seconds, 3 to 5 seconds, and then I'm going to touch child's ear if she cries. Now she's 10 months old. She cannot tell that there's a pain. So you can alter your like yes your warnings like this. If she cries, I would stop. Now you're talking to mother. If your child cries, I would stop. You have warned the mother that I'm going to examine. Palpate, okay, that's fine. Now I'm going to insert this instrument in child's ear. If she cries, I would stop. Okay, now insert it. Remember the technique. Usually it's in the either in the right ear or left ear, whatever the ear. Don't confuse yourself. Always remember right ear, right hand, left ear, left hand. Usually it comes with the right ear. So right ear, the otoscope should be in right hand, and with the left hand, pull the ear pinna upwards and backwards. Okay, now one, I'm going to insert it and see what do you see. This is normal picture. This is a normal picture. You would see the ear looks like this, but you will see like this. This is acute otitis media. There would be pink color tympanic membrane. Now you have confirmed it. You took the history. There was a fever 2 days ago that started. The child is having a history of pulling her ears. Three things. You were having a suspicion of acute otitis media. Now you examine. There is a redness. It's confirmed that it is acute otitis media. Now thank the patient. Look for now. Obviously, after palpation, you check the light and check for any other abnormality, and thank the mother and sit on your seat. Now start explaining that what you have examined. Okay, Jessica, thank you so much for examining for giving me a chance to examine your child. I just examined your child's left or right ear, and I found that the tympanic membrane is pink, or the inner your baby's child is pink, which shows an infection. It could be viral infection or bacterial infection. Since it is for 2 days, probably it's viral infection. Okay. So now you have to explain it. It's the infection which is caused by a bug called virus, and it is called acute otitis media. In simple words. Okay, that's a good question. Actually, in the real situation, the real clinical settings, you need to examine both ears. But in the exam, the mannequin you cannot change rotate the mannequin. It's fixed. So you can mention only you can just mention to her mother that I am going to examine her other ear as well. The real exam, actually, you cannot rotate. I have shown you that the mannequin would be like this. So you can it would be tilting. Her right ear would be upward in direction. So it would be in tilting direction. Let me show you. It would be like this, in a tilting position. So you cannot examine the other ear because it's fixed. So you can only, what you can do is you can mention it. I would like to examine other ear as well. So that's because of the mannequin. You cannot examine in real life, like station. You cannot examine. Okay. So now you have explained the mother that what's going on. It's the acute otitis media, that is the infection of the ear that is caused by bug virus. Now let's discuss management. Usually it comes with 2 days. If there are 2 days, then most probably it's viral infection. And when do we start antibiotics? If it's more than 4 days, remember this. I just copied it from NHS website. So remember, if infection is older than 4 days, if the infection is in bilateral in the both ears, and there is a perforation or red tympanic membrane, then you go for antibiotics. If there is a history of 2 days and the tympanic membrane is pink, then it's probably because of virus. So what you would do? Supportive treatment, paracetamol, and make sure child is eating and drinking fine. Now, we have discussed one thing about the discharge. In the history, there was a discharge of greenish fluid, and no one is sure about either it was from mouth or from ear. How can we handle this? The one approach is that we can say that, look, Jessica, you mentioned about discharge, a greenish color discharge. So at this point, I am not sure what's going on. So I would like to consult your child's condition with my senior. On the safe side, you can consult with senior as well, because you're not sure other greenish discharge from the mouth or ear. Usually, greenish discharge doesn't come from the ear. It could be a biliary atresia or something else, or it could be simple vomiting. But on the safe side, I would like to consult with my senior, then you can go home. So now you have, let me summarize all this. You have good 90 seconds. You're standing outside now. You're getting you have got a you have got you made up your mind that there's a child 10 months old, and she is compliant with her mother. So you start taking history, and after taking history, you are getting idea that it's acute otitis media. You have asked 5 questions about development, pregnancy, and immunization status, and about past medical history and allergies. These 5 questions are important. And then you go for examination. In examination, you have found there's a pink tympanic membrane. You explain findings to the mother, probable diagnosis acute otitis media. And then to confirm it, I need to consult with my senior. And there's a management approach. It looks like it's caused by a bug called virus. So there's the medicine for fever, and you need to give plenty of fluids. And at the end, do not forget about safety netting of meningitis, because it's common among children. So if you notice that a child's neck becomes stiff, or a child is unable to hold her neck, just go to accident emergency or call 999. And pain or not control, or if this infection doesn't settle down in 4 days, we will go to accident emergency, or GP come back to us. We will start antibiotics. You have to safety net for 2 things. One is meningitis, second is antibiotics. So this is a simple approach. And remember, there are marks for safety netting, for leaflets. If there's a GP setting, then always offer leaflets. There are 4 marks for management. Among the 4 marks, one is for treatment, one is for safety netting, one is for leaflets, and other is for explaining understanding of the patient, or the child, or whoever in front of you. So these are the 4 marks. So do not forget about safety netting. This is the important thing. You cannot send them without safety netting. So this is a simple approach. Don't confuse yourself with a discharge. Just pick points. If there's a fever in the child, start ruling out. You would ask mother that, tell me more about child's condition. Doctor, I don't know. She's not feeling well. She would continuously say this. Okay. So have you noticed any loose stools? Have you noticed that whenever she pee, she cries? Have you noticed that she's not passing poo? Or any cough, any flu-like symptoms? Okay, no. Any problem with the neck, like difficulty in holding neck, or neck stiffness? No. All right. Have you noticed that child is pulling her ears? Yes, doctor. That is there. You will get an idea that it is acute otitis media. So, and in the feedback I got from the candidates, there were like 2 to 3 candidates who completely forgot to examine. Do not do this. Remember, the room will be bigger, and on the in the outside the cubicle, it would be written that examine. So do not forget to examine. Always there would be a mannequin on the right side, or probably in the square. There's a Hardman square. The mannequin would be on the right side. So don't forget to examine. So let's move on to other scenario. It's earwax. It's also coming nowadays more frequently. So you are ever to a doctor in GP surgery, Theresa Scott, a 45-year-old lady who has presented with some complaints, assess patient, discuss management. Okay, these are the patient information, like she's 45 years old. Okay. In this scenario, it comes with male and female both. In the scenario, when it comes with the male, he's a businessman, and the important point in this scenario is this history, travel history. So he or she traveled 2 weeks back to Spain or Caribbean region, and he was there swimming, and after swimming, these symptoms started. And what are those symptoms? He would say, doctor, there's difficulty in hearing, like decrease in hearing, and there's a pain in my ear. Yes, this is. I have earache and decreased hearing. Either he or she would say either one of them. Doctor, there's a pain in my ear, or there's decrease in hearing. Okay, and since how long? For 3 days. Now you start taking history. You start ruling out other, like, have you noticed any fever with that? Have you noticed any discharge? Is there any redness? Complete your history questions like OD-para and PIM, of course, complete all these things. You will not find anything significant unless you ask about travel history. Have you traveled? No. Whenever the patient comes with the ear symptoms, you need to ask about swimming. So, by chance, is it possible that by chance you went for swimming in the past 2 weeks, 3 or 3 weeks? He or she would say that, yes, doctor, 2 weeks ago I went for a trip to the Caribbean or Spain. There I went for swimming. So after that, these symptoms started. Then you will get an idea that it's just swimming and there's decreased hearing or there's earache. In this scenario, she would say this, this is the total history. You would ask about fever, chest pain, shortness of breath, and a lot of other diseases, including culotus media, otitis externa, trauma, upper respiratory infections, all would be negative. So you have the history. Now, important thing is it's for 3 days, and he's a businessman. Now there comes the point that you can act as a safe doctor. How? Ask how it has affected your life. It's been 3 days and he's having problem with the ear, like hearing, and there's a pain in the ear. Ask, uh, what do you think? Like for the past 3 days, is it affecting your life, and how is it affecting your life? He's a businessman. He would say that, yes, doctor, I have been taking rest for the past 2 days. I have not been able to go to oversee my business, or I have canceled my meetings. Now there's a time to address his or her concerns. Don't worry, I am here to help you. I will examine your ear quickly, then I will make a probable diagnosis. Now there's time to address. Show that I'm a safe doctor. I'm concerned about the ear, that I understand that it's for 3 days, and it is possible that his job has been affected by this. So there's the point that ask about effects of symptoms on patient's life. Okay. So these are the questions that patient would ask if you in the ICE questions, like if you ask, like, what do you think it could be the cause, yeah, or what do you think, what are your take on this condition? So he or she would say that, doctor, why do I have, okay, okay, these are questions. These questions she would, or he would be asking after making diagnosis. So let's see. Uh, when you ask effects of symptoms on the patient life, then you move on for the examination. Okay, John, I need to, or Jess, or Teresa, okay, I need to examine your ear. Before that, I would like to take your observations, include your temperature, pulse, respiratory, and blood pressure. And now I would like to examine your ear. Same, it would be a bigger room, there would be a mannequin, okay? And same, the mannequin, you cannot rotate the mannequin. Now that was a good question. Now you can mention that I would like to examine your both ears. If it was the normal one, then there's in the ear where there is a pain. So now you go there, you follow the same approach, explain that there is an instrument that I'm going to insert it. It should not be painful. Can I proceed? Take consent, then go there. Pick the otoscope, and you will see like this. There are two possibilities. It comes with two possibilities. You will see this, or you will see normal tympanic membrane. Okay, so you have examined, and like you have done inspection, palpation, everything. There is no tenderness. There's just problem in the ear, and then you see in the otoscope there is this black thing. This is wax. This is the picture of the wax. Okay, so I just have examined three. So I have examined your right or left ear. Your right ear is normal. Your left ear shows there's a wax, and probably it is because of the swimming, the water that went into your ear, that might be the cause of this wax. Okay, And now you can explain the pathology as well. How earwax is formed from the sweat and dead cells which are produced in the ear. You can discuss more about earwax protects the ear canal, because in this scenario, she would be worried. So you need to say something that she become relaxed. So because in the general public, they are much worried about the earwax, that they might lose hearing. In questions, she might ask you that, doctor, will I lose my hearing? Or a question like this, then you have to relax the patient. No, it's a normal procedure. Wax production is a normal procedure. It protects our ears. So however, it doesn't, these are the lines. Just give a read. If she asks any questions, so that you can address those questions. Okay, swimming can also cause blockage of the ear from the wax that happens. Water causes wax to expand. Physiologically prone to produce more wax, and hearing loss will improve once the wax is removed. Okay, now comes the management. There are two managements. If there is a wax, then there is this management. Ear drops, olive oil for 3 to 5 days, it will dissolve the wax. Okay. If it does not improve, then we can do irrigation. We will discuss about it later on. And advice about hygiene, cover your ears when swimming. It is advisable that you should not go for swimming unless you get treated, and avoid using cotton buds. Use olive oil or almond oil. This is the management when you see this in the ear. If you see that ear is normal, there is a tympanic membrane like this. This is normal ears diagram like this. This tympanic membrane, everything is normal. Still, she is having decrease in hearing and pain in the ear. Then you need to refer at the first presentation. However, if there is wax, then you give the management this and ask him to follow up in 2 weeks' time. Okay, so, and also tuning fork test, you need to mention it, because there is loss of hearing. You just need to mention it. When you will mention it that I'm going to perform some tuning fork test as well, the patient or examiner would give you some papers, and on those papers it would be written that Weber and Rini's tests are normal, or the normal findings would be given. Okay. Okay, this is the same management. Okay, safe netting, that's again important. High temperature or worsening of pain or worsens hearing problem. If you notice any of the things, just call 999 or go to the extended emergency or come back to us. Concerns. Now the questions she would be asking you that, how can I stop this from happening? You cannot stop earwax. It's a normal procedure. It is for the protection of the ear. Okay. How often do I have to clean my ear? You don't have to clean it, or but you can try and put ear drops over the week if you notice that you develop earwax too frequently. You can handle concerns like this. Just give the normal approach. Don't give answers like the. Okay, the one concept is confuse the patient. Don't give exact answers. Always give diplomatic answers. Like, you should, okay, you can clean your ear, but it is not advisable. It can worsen your symptoms. So if you need that, if you need an urge, or if you feel that there's a wax, you can instill some drops in your ear. This one approach that you are involving patient in conversation and in the management. All right. So it's the first presentation. It's the first day, like it was 3 days ago started, and she's having earache, ear and decrease in hearing, and now you are going to address, you start examination, there is a wax, and you manage the patient very well. Now there's another scenario. You ask the patient, you have seen there's a wax, and you did this management. Now after 2 weeks, patient comes again. Now, how to approach it? This is the follow-up. Follow-up approach is slightly different from the first one. You are standing outside the room, outside the cubicle. In the scenario, it's written that the patient came 2 weeks back, same history. There was the earwax, and the management was advised she has come back again, addressed concerns or whatever. Now you enter the room, you follow the follow-up approach. What does that mean? That means that it will give you a good impression that you start by patient's name. Okay, Teresa, it's good to see you again. My name is Junaid. I'm one of the doctors. How are you? How are you doing? How are you feeling? Now, so I can understand that you came here 2 weeks back. So what were you told? Now confirm it. You already know that outside the cubicle it would be written that she came 2 weeks back. Now you have to confirm it. Just ask the patient what she already knows. So she would be repeating all the above history. She came, there was a wax, and the doctor gave him the almond oil or the olive oil to instill. She would be saying all these things. Okay, what investigations were done? Okay, there is some tuning fork tests or some blood tests, whatever, and what management? They asked me to instill some drops. So did you follow the advice? Yes, doctor. How are you feeling now? Same, doctor. There's decrease in hearing, there's a pain in my ear, doctor, please do something. Don't worry, I'm here to help you. Okay, so I need to examine. I can understand that you came here 2 weeks back, there was a wax in it, so I need to examine you again. Just a quick history. Before that, I would like to ask a few questions. So have you ever been diagnosed with any general medical condition? Do you have any allergies, past medical history? What did you do for a living? And how it has been affecting your life for the past 2 weeks? I understand that you have been suffering from this for 2 weeks. How it has been affecting your life? Now you're showing that you are concerned about his life as well. Okay. She would be saying number of things like, doctor, I'm having difficulty in organizing meetings or whatever. I just address whatever she says, and I understand that I will see that what's going wrong with it, and how why you are not feeling well. Examine again, and the examination again there would be two possibilities. There would be a wax, there would be normal finding, no nothing, normal ear. Then again management would be same, refer. In this case, you do not need to repeat this management. There is no need to repeat this. Now some other pathology is going on, because two things, decrease in hearing and ear pain. You are GP, you are referred to. Now the thing is that 2 weeks have already been passed. If there is a wax, there is need to remove this wax. If there is no wax, then there is some other pathologies going on. So in any way, you need to refer to the ENT surgeon. Okay. In some GPs, they remove wax. So if you see wax, so you can alter your management like this. I will consult or discuss it with my seniors. Either we can remove your wax here or not, and I will get back to you. So in some GP surgeries, when you visit the NHS website, you will see that in some GP surgeries, they remove wax. So you can alter your statement like this, but most of the times the wax is removed by ENT surgeon. If there is no wax, then there is some other pathologies going on. There is need for MRI. So I'm going to refer you to the ENT surgeon. They might perform specialized investigations called MRI to diagnose, all right, to diagnose what's going on. So I can understand that it has been 2 weeks have already been passed, and you have just give some address her emotions. She's having this infection for 2 weeks. You need to address in a way that she thinks that doctor is very much concerned about my condition. Show some concerns. I understand that you have been suffering from this condition for past 2 weeks. It must be really very difficult for you. But don't worry. Now we are going to run some specialized investigations, and we will get to know that why you are having this. So for that, we need to refer you to the ENT surgeon. Now ask, would you go to the ENT surgeon? This is how, when you start the management like this, you involve patient. Okay. Would you go to the ENT surgeon? Okay, yes, doctor. So do you want to know what ENT surgeon would do? Yes, doctor. They might run some specialized investigations, then explain, and then again at the end, safety netting is important. Safety net, give leaflets, and that's all. This is the ear wax scenarios. And again, when you are going to tell the management, yes, I have the candidates sometimes say that I explained everything in the management, but I did not get even 1 mark in the management. Why? You are repeating these lines like now there you have to do 3 to 4 things. You have to instill drops. You have to whenever you go for swimming, you use something to cover your ears. You use avoid using cotton buds, whatever. Don't do this, okay? Involve like this. Okay, Jessica. Now there's a wax. I have seen from my instrument otoscope, there's a wax in your ear, and I have explained why the wax has been formed. So now we need to remove this wax. So there are few things that you have to do. So you have to instill eardrops. Will you instill eardrops? Would it be easier for you to instill eardrops? Ask about like is it easier for you, like involve? Okay, doctor, yes, I can do this. Okay, you have to do 3 to 5 times in a day for 2 weeks. That's great. Then okay, and then do you use cotton buds? Ask. Okay, yes, doctor. Do not avoid because it can worsen the symptoms. Okay. Do you go for swimming nowadays? Are you going for swimming nowadays? No, doctor. It's better. And if you're going for swimming, just cover your ears. That is the way you're telling the management, but you are involving the patient as well. Step by step. Give information in chunks and check either she can do this or not. So same way, when you are going to refer patient to specialist, ask, would you like to go to the specialist? Okay, it reminds me one scenario. Okay, we are done with the earwax. Let me give you an example of one scenario. There's a scenario, the patient comes with heart symptoms. There was an MI. The patient had this left chest pain, and it adheres towards arm. And it was, when you ask take the history, it was MI. Okay. Now in the management, when you would say that I need to refer you to the specialist, he would abruptly would said that, doctor, I don't want to go to the specialist. Okay, so why you don't want to go to the specialist? My father died in the hospital. So that's why you need to ask, would that be possible to visit the specialist? Would that be possible to visit hospital? That's why you just take permission on the patient that it is better for you to visit specialist. And then you are going to give some information, ask, are you interested in the investigation that will be done at a specialist? Because sometimes, like when you break bad news in the cancer patients, they do not want to hear about investigation. They do not want to hear about for the they just not feeling well. You have to address those concerns. They don't want to hear about radiotherapy or chemotherapy. They don't want to hear about CT scan. So whenever you're going to give medical knowledge, ask either he or she wants to know or not. That was now we are done with ear examination. Remember 3 stations: one with the child, 2 with the adults. Earwax, first presentation, second presentation, child, acute otitis media. Other scenarios with the ear problems, these are not combined stations like tinnitus, acute acoustic neuroma, and Meniere's disease. And there are a few more scenarios as well, but these scenarios are only history-taking scenarios. In those scenarios, you do not have to perform examinations. Again, in practice, it looks like that it would take longer time. But when you just after this class, you can pick the pen and you can just you can say that it's otoscope and you perform it. It won't take more than 30 to 50 seconds. Okay, so you have to complete your examination in 1 minute or at max 1.5 minutes. Now I'm going to share the link. for otoscope examination. Okay, this is the link. You can skip Weber's and Rennie's part because you do not have to perform this. There would be no tuning fork there in the real exam. So you can skip Weber and Rennie's part, and you check. You can just mention it. In the child, there is no need to mention because it's acute otitis media. The history tells that it's acute otitis media, and you cannot do Rennie's and Weber's test in a child because in those tests you ask about where there's vibration or not here, all that. In the adults, you just mention it where I'm going to perform tuning fork tests as well. So in this video, there are few things that you need to notice. What is the position, how he's holding otoscope, and how what he's doing with the left hand, okay, and how he takes consent. So when you're done, just let me know. That's great. Look at this. This is the position. Remember, you can hold the head of the mannequin with the 3 fingers of your left hand. With the 2 fingers, like a pincer grip, you can hold the pinna, and then by the 3 fingers, you can hold the head as well. And the other hand should be touching the cheeks of the mannequin. That's how, when you will be doing the otoscope examination, your otoscope will not be moving or swaying in the air. It would be fixed. From the left hand, the head. From the right hand, it should be touching the cheeks. So when you're going to examine, it should not be like moving or vibrating. So that's the otoscope examination. So let's move on to the antenatal examination. In the antenatal examination, there are two things that are important. Either there is a breech presentation or cephalic presentation. So we will be seeing that in these examinations, how we are going to proceed further. Okay. Approach is same. Being a safe doctor, introduce yourself, explain what you are going to do. You're going to examine the tummy. Why? Because I need to check the position or presentation of the baby. Okay, so it will be involving touching and giving some pressure. So can I continue? Can I do the examination? Take consent and ask for chaperone as well. Because you want to examine tummy. If it is only tummy, then there is no need. Then okay. So this is the way you can tell the patient, I'm going to examine you. It should not be painful. If at any point, if you feel any pain, just let me know. I will stop. Consent, position, expose. The exposure is needed for tummy. That I can examine your tummy. Again, ask for pain. Before touching, ask for pain. If there's any pain, let me know. Then inspection, palpation. Palpation, you do 2 things: fetal lie and fetal presentation. And then at the end, thanks. Now, again, the real antenatal examination, you need to examine hands, eyes, face, and it's a longer examination. It's not that simple. But because it's a combined station and you just want to confirm something, in this scenario, we would be seeing that we need to confirm either breech or cephalic presentation. So you are just confined. You just need to confirm either it is breech or cephalic. Just confirm this. So you only perform palpation, which includes fetal lie and fetal presentation. Only 2 steps. We do not go for hands, for facial features or any pathologies, because you are not doing full antenatal examination. It's not teaching, remember. If it comes in teaching, then you start with the hands, with the face, and you tell each and everything. But if it comes in combined station, you just need to confirm either it is breech or cephalic. Then you just go for palpation, inspection, palpation, and either it's breech or cephalic. That's done. We will just see in this examination, in this scenario. Okay. So you are who you are. You're a F2 doctor in obs and gynae. Mrs. Sandra Wilkinson, 26-year-old lady, para 2, who is 36 weeks pregnant. Okay. Okay, you are standing outside the cubicle. The things that need to be focused on are: she is 26-year-old and pregnancy is 36 weeks. Okay. Mrs. Sandra Wilkinson has come to the hospital for a routine antenatal visit. She has been seen by a midwife who has found the fetus to be in breech presentation. The midwife has asked you to see the patient. Examine the patient, important thing. Discuss initial management with the patient. Now, you're standing outside the cubicle, you have good 90 seconds, just have a focus on the statements. Midwife has already examined and the fetus to be in breech position, breech presentation. Now, just clear your mind that the examination has been done, antenatal examination has been done, it's a breech position. Now, what your duty is, just confirm whether it's breech or not. That's why you do not need to perform whole examination from the hands, face, and the tummy and the abdominal. You just need to confirm it, either breech or cephalic, because examination has already been done. Just focus on the words of the scenario. So what's your task? Examine the patient. It's written outside. Examine. Go inside and examine and discuss initial management. Okay, so let's see how we're going to approach this station. This is some patient information. She's similarly 36 weeks pregnant and no past medical history, third pregnancy, spera 2. Okay, she has two other children, age 2 and 5, who were born by normal vaginal delivery. These questions you need to ask before examining. You know, in each and every type of scenarios, in every kind of scenarios, you need to ask few history to confirm what's going on. So you need to ask about previous histories, previous, now it's a breech presentation. It is possible that the previous could be a breech. So it could be one of the risk factors. So that's why you ask about previous deliveries. So those were the normal vaginal deliveries. She is 36 weeks pregnant. You already know, but you can ask. So I understand that you are 36 weeks pregnant. So is it which pregnancy is it? It's third pregnancy, doctor. What about the previous two pregnancies? Was it normal? Yes, doctor. Okay. Okay. Have you started feeling kicks of the baby? Yes. She's sitting right next to a mannequin. They would be mannequin. Again, a larger, bigger room. They would be mannequin. Okay. Okay. These are 3 to 4 things. And she just tell okay. If you ask too much about the history, she would say, doctor, everything is fine. The midwife has already taken the history. Okay. If she verbalized these things, then now things are clear. You do not need to ask anything. She or the patient giving you clue that go for examination. There is no need to ask any more things. So this is a clue, one of the clue that you should go for examination. Okay, she usually doesn't give too much history. She gives history that has already been given to you in the scenario. Other than that, she doesn't give too much history. Okay, these are the questions she would be asking you after you diagnose her, after you tell the patient that what's in the examination. So now you have spent good 90 seconds outside the cubicle. You have understanding that you are going to examine, and you are going to examine patient to confirm either it's a breech presentation or not. So you enter into the room, smile, be loud, confident, paraphrase. One of them, okay, I understand that one of the midwives says, have examined you. What did she tell you? What did he tell you? Whatever. So just ask. So what she told you? Like, it is possible that the midwife has already told her that it's a breech presentation. So okay, did he explain to you? Did she or he explain to you? Either it was what does the breech means? Okay, so check the understanding first. What patient already know. If she knows everything, then there's no need to tell to give more knowledge. Just go for the examination. If she doesn't know, okay, doctor, the midwife didn't tell me anything. She just asked me to visit doctor, and the doctor will tell you everything. So that's why I'm here. Okay, don't worry. I will quickly examine you, and after that, I can see the notes. I will be at a better position to tell you what's going on. Okay. Again, there's the patient information. You have to ask all this information in the question form, like how many weeks, any high blood sugar levels, just your first pregnancy, how many babies you're expecting, are you feeling cakes on the baby, any problems with previous pregnancies, preeclampsia, abdominal pain, or bleeding in current pregnancy. These, the preeclampsia, or you need to rule out all these things, because if there's a breech presentation, there's the possibilities that she might deliver by a C-section. So you need to rule out this preeclampsia as well. So if in between the history, she tells you that, doctor, I don't want to give history. Okay. I'm sorry if I annoyed you. I would just proceed toward the examination for confirmation. Can I proceed? Okay, my examination will include examining your tummy, and it will be, I will bring some maneuvers. I will be palpating baby. So would that be fine for you? Just like the midwife did. because the examination part has already been told to her. You can mention midwife as well. Be smart. Okay. Explain, take consent, and start doing procedure. Whenever you're going to touch, warn the patient. If you feel any pain, just let me know. Okay. Any problems, be gentle. Is there any pain? Ask. Obstetric grips and frontal. Okay, frontal height. There would be a possibly there would be a meter tape, and you can take frontal height from that. But grips are important. These grips need to be learned because when you're going to examine the real baby, the mannequin, then when you're going for the grips, you would have an idea there's a breach or not. Now game is upon you. You need to confirm it. This scenario comes in two ways as well. Either that would be breech or that would be cephalic. This scenario comes in always like, okay, if it comes breech, the midwife was right. If it's cephalic, well, I'm not sure at this point. I need my seniors to come and examine you again because I do not think that it's a breech presentation. You can alter your statements like this. But for that, you should know what's breech and what's cephalic position. For that, you should be aware of what's the obstetric grips and how to palpate head and how to palpate buttocks. Usually buttocks are larger, and one more indication is that when you palpate baby from the sides, fetus from the sides, you can palpate the back of the fetus. If there is a back on the right side, then obviously head would be downwards. It's just belly position. If back is towards left side, then the head would be upwards. It's a breech presentation. I will just show the video. In that video, it will be clear that how you palpate the fetus and how do you check the presentation, either it's phallic or breech presentation. Okay. Now you have examined the baby fetus and its breech presentation. How you're going to explain your findings? Okay. Start with the good news. You have done examination. I will show you the examination part and then say thank you and start with the good news. I can hear the fetal heartbeat and tape measurements was also normal. There's only one thing I found: the baby is laying in breech position. Breech presentation means the baby is laying head up and buttocks down. That's not the normally baby present. Okay, the majority of the babies at this stage pregnancy would lie at the head down and buttocks down. Explain, and then there is the management. Okay, now just 5 minutes break due to azan, and I'm sharing with a video of obstetric examination. You can see how you can palpate the head and the buttocks. Okay, that's great. Okay. You can see that this video is of 3 minutes and 31 seconds, but the palpation part is just 20 to 30 seconds. So there is no need to perform initials. There is no need to perform the inspection of the hands and face. Just keep all those parts, because remember, now you need to confirm either it's breech or not. Everything has already been done. So just go to the palpation, inspection palpation, and that's it. So it won't take more than 1 minute. Okay. Now, management is important. Okay, it's she's 36 weeks, I guess. Yes, she's 36 weeks pregnant. So we do external cephalic version first. And what are the indications that it is usually done at 37 weeks? Okay. Okay, for the external cephalic version, we will wait for 37 weeks. We will wait until 37 weeks. If she's 36 weeks, we will call her after 1 week. And if she's 34 weeks, then after 3 weeks, we will be doing this external cephalic version. Okay, and there's one more thing about it. Yes, this is. External cephalic version is indicated at 36 weeks in primigravida and 37 weeks in multipara. Okay, so this it's her third baby. So at 37 weeks, we will be doing external cephalic version. If she's 36 weeks, and when we will be doing external cephalic version? At 37 weeks. And when we are going to ask her to come back? After 1 week. It's 1. Okay, it's 1. Okay, after we will be calling her after 1 week. That's how we start with the management. Now, in this scenario, initially she will not be giving you too much history now, but at the end she will be asking too many questions. I have collected all those questions, like, are there any complications when will be. She would inquire that what is this the procedure, external cephalic version, what is this? When you will explain it, it's like this, it would be done by a specialist. Then she would be asking number of questions. Are there any complications? Is breech dangerous? Is this maneuver dangerous? What is the cause? And then when will you explain that if the external cephalic version is not like we fail in this maneuver, then we will go for cesarean section. Explain each and everything to the patient. Then she would be asking questions about cesarean section. Is there any chance of me having normal delivery? And what can you tell me about C-section? These are the questions. Just go through all these questions, because she will be asking like 4 to 5 questions in this station. So she can ask any 3 to 5 questions from them. It depends upon day to day. Okay, what are the complications? And complications of cesarean sections are bleeding and infection. Okay, I have written all these things. Just go through them. Okay, there are complications: pulmonary embolism, bleeding, infection, wound infections, long hospital stay. Okay, damage to surrounding structures, and explain that you will talk to the consultant to get back to the patient. And these are the important things that just go through them once. It's we asked preeclampsia question in the beginning, because external cephalic version is contraindicated, and these are the things. If she asks questions, you can mention them, these things. Otherwise, there's no need to mention these things. When you will be saying about external cephalic version or about C-section, she would be starting she was starting asking these questions. So just address those concerns, and that's fine. And at the end of a leaflets or breech presentation, in the beginning, when you will break the news that it's a breech presentation, and there's a possibility that we may go for external cephalic version or cesarean section, she might show some emotions. Then this is the point, that show and address her emotions in a way that she thinks that you're safe, doctor. Like, I can see that this is these are the hard times on you, but don't worry, we are here, doctors are here, specialists are here, we will help you in any matter. just give some support. That's it. That's the breech presentation. Now there's swelling presentation. Okay, the breech presentation also comes with cephalic presentation. Sometimes it has happened that the midwife examined, it was breech, but when you examined, it was cephalic. In those situations, you have to involve seniors because you are required to, you're not that expert. So you need to involve seniors. I would like to involve my seniors because I think it's cephalic presentation, it's normal, but midwife says against it. So I would like to consult it with my seniors. Okay, so now as for representation, you are ever to in Obs and Gynae, Emily Brown, 30-year-old lady who has come for routine antenatal follow-up. Her last antenatal was 5 weeks ago. When the midwife examined her, the baby was in breech presentation. Now, that's a good, I was talking about similar scenario like this one, okay? 5 weeks ago, when the midwife examined her, the baby was in breech presentation, okay? Now, just you have good 90 seconds, focus. She had come back today for her follow-up appointment. She is 36 weeks pregnant. Examine the patient, discuss management. 5 weeks ago, she came. She was having breech presentation, but now she has come back. Now you need to confirm again either it's breech or it's cephalic. Again, patient information: 30-year-old lady who has come for follow-up. Okay, that information is same that is written outside. Okay, so this is the note. Just read it. I understand that there was a breech presentation. The midwife told you, but I need to examine further more to confirm this. Okay, so I understand that you have come for routine and to follow. How are you doing? Now again, it's a follow-up. Again, so midwife examined you in the last when you came last time here. So what did she tell you? And what is your understanding about breech presentation? Okay, and ask about all these questions. Was everything okay at your last antenatal follow-up? Okay, ask any bleeding in pregnancy, preeclampsia, headaches, problems with your vision, swelling with the legs, tummy pain, swelling of your face, well-being of the baby. Are you feeling kicks of the baby? Okay. Past medical history, there is no need for differential diagnosis, nothing. Allergy history, yes, and examination. Again, in this scenario, she would be giving you all the history because she in the end she would have less questions or less or no questions. She would be asking like 2 to 3 questions, no more than that. So again, you need to examine, check observations and enter examination. Now, in the scenario, it was written as breech presentation. Now, when you are going to examine, you're going to palpate, do the obstetric grips, you will find out that it's cephalic presentation. Cephalic presentation means that heads downward, buttocks upward. Now you start explaining the findings. The baby is now cephalic presentation, which means baby is lying with the head facing downwards and buttocks upward. So now what we are going to do, we need to confirm it. Also, 2 things. We need to confirm by the seniors and by the ultrasound scan. Okay, and we will be doing urine test and CTG scan for the fetal well-being. These are the scans for the fetal so that we can, because previously it was breech, now cephalic, so we need to check the fetus well-being as well. 2 things, senior and ultrasound scan, CTG as well. So after that, there are a few advices that I would like to give you. Just eat healthy, mild exercise, or ask about mode of delivery, what she has decided, and the same history that you take in obstetric cases or gynecological cases. Okay, safety netting again, preeclampsia, any headaches, vision problems, and tummy pains, she should come and see GP. Safety netting is same. So in this scenario, look, just focus on the approaches. How the approach is different in when the patient presents with the breech and the breech is confirmed, and if the patient is breech and cephalic is there. So how the approach changes? Cephalic is normal. So just talk about general terms like mode of delivery and eat healthy, do some exercise. That's how you're going to approach this station. Again, so we're done with our 5 scenarios today, year and antenatal examination. Remember, it looks like that it would take like 3 to 5 minutes, but I have shown you the videos. These videos are just not more than 3 minutes. And in these videos, again, you have to be specific. You do not have to do all the examinations. You just need to confirm what's going on. So be specific, perform these examinations under 1 minute or max 1.5 minutes, present well to the patient, always follow the steps of safety. What are the steps of safety? Explain, take consent, chaperone, whenever you are going to touch, warn, and then say thank you. And today we did ear and genital. In the previous session, we did abdominal and testicular. And there's 2 more combined stations. One is prostate and the other is fundoscopy. In the fundoscopy, it's always normal. If the fundoscopy comes in a real exam, it's always normal. The approach is same. You have to, if you are going to examine right eye, fundoscope should be in right eye, right hand, sorry, and your right eye, your right hand, your right eye. If you are going to examine the left eye of the patient, your left eye, fundoscope left hand, or patient's left eye. So usually fundoscopy is not coming. It was coming before the COVID, but nowadays fundoscopy is not coming. If it comes, then it's normal. There's no abnormal findings in the fundoscopy scenarios. And the prostate examination, we will see. We will try to do this in next session. So that's all for today. If you have any questions, just ask me. Yes, yes, I'm just recording this video. After this class, I will upload in YouTube and then provide the link. Don't worry. Okay, any questions so far? Remember again, thank you so much for the acknowledgement. But remember, this exam is for safety and kindness. When you will appear in the the invigilator would say that, doctors, we have assessed your clinical knowledge in Player 1 exam. Now we are going to assess whether you are safe and kind doctor or not. So there are few things that you should show the patient and the examiner that you are worried, you are concerned about the patient and patient safety and all those things. These things carry marks. In real life, to be honest, in being a Pakistani, we don't focus on these things. We don't take consents or warn the patients to just go on and go on. Don't do this. Okay. All right, then. I hope everything is clear now. There are no questions. So we're going to end this class now. Thank you so much for your time. Come.